This is the seventh in the cardiovascular system. Major vessels, we're going to talk about some cases and hormones. Carotid artery disease, and then arterial aneurysms, dissections, veins, and the heart as a secondary organ. First question right off the bat, 4 arteries supply the brain. Why is it necessary to have so many arteries? Is it extra backup for blood supply or better blood drainage? This is a trick question, because the answer is extra backup for blood supply. Notice how there's 4 carotid arteries, 4 arteries, 2 carotid, 2 vertebral, and the veins are the jugular, which drain the neck. So the internal and external jugular have especially the right side has a direct pathway to the heart. The external jugulars are great for doing external like jugular vein sticks if you can't get a peripheral vein in the hand or the arm. So all these arteries, 4 of them, provide a backup system. And I'm just showing a picture of a person getting their hair washed, and their neck is compressed, the vertebral arteries, by those ceramic bowls. The problem with these carotid arteries and the vertebral, but mainly the carotid, is that they're so close to the heart, that high pressure system, that they have a tendency to develop plaque. And they tend to have this plaque development at this bifurcation, internal and external carotids. About right at that bifurcation, lots of turbulent flow there. So the next case presentation, patient I've taken care of in the operating room, is a 74-year-old woman. She came in with episode of slurred speech. She had left arm weakness, so that's a diagnosis of a stroke. If it completely resolves, it would be a TIA, or transient ischemic attack. And so they found that there was plaque in her carotid artery. Carotid artery disease is when this plaque forms, and this is what a piece of plaque looks like. This is not hers in particular, but with plaque, notice how these areas, that's where the cap broke off of the plaque, and blood clots starts to form in these roughened areas because platelets start to congregate. That rough area forms a blood clot, and then that can break off, and a person can have a massive stroke. And remember from when we did coronary artery disease that cholesterol gets pulled into these areas where the endothelium's been disrupted. The treatment is surgical, and the neck, make an incision in the neck, and this is the bifurcation of the internal and external carotid arteries, and then a dissection of that plaque out of the artery. So this is a brief ultrasound they do. Put the ultrasound on the neck, make marks with a little permanent marker, or eventually it comes off, but they make a mark so that they can see where their incision is going to be. And so they're identifying the carotid artery, the common carotid. There's a little piece of plaque you see, and then they can scroll down and see where the split is, so they can make an excision right over top of where the artery and the plaque is. And that's done before the incision. Now, during the surgery, a shunt gets placed. It's just a piece of plastic, and prior to the shunt, the patient gets heparin so that the blood is less easily clotted. And then at the top and bottom where these shunts are, there'll be a suture, a ligature that goes around there just to hold the blood flow from coming into the incision site. And then this is the plaque is dissected out of the internal carotid. And this is the actual image of this particular patient. This is showing him just picking apart this plaque and dissecting it out. The shunt's already in place. It's hard to see it. The shunt's about, that's right there. And these are ligatures, and they have red plastic tubing that holds it down to keep blood from filling up the surgical incision. What is a significant risk with this surgery? Is it bleeding into the neck and causing an airway obstruction? Is it from stroke, from clot or plaque, pieces of plaque? As you notice, it doesn't peel off in one single piece, or both. And the answer is both. Notice that the bleeding into that area of the body is particularly dangerous. If it gets large enough, it'll compress the trachea. And this is actually her plaque that was removed. So it comes out in pieces. It's hard to dissect away one single piece of plaque. Okay, let's go on to the other major vessels in the body. Aorta, inferior vena cava, blood going back to the heart, and superior vena cava, blood is going back to the heart from the upper extremities, from the head and the upper extremities. And these are the body's largest vessels. Depiction of the aorta and the inferior vena cava. So now you're working in the anatomy lab. You're looking over cadaver, and it's not going to be color coded. It's just everything's going to be gray. How can you tell the aorta and the inferior vena cava apart? When the body is drained of blood, would the vena cava be flat or round? That's your first clue. Think about the physiology, the dynamics of those major vessels. And the answer is the vena cava is going to be flat. This is an anatomage video, just the veins. It's just showing the veins that are in the abdomen. And this, they've taken away the small intestines, the large intestines are around. And notice how the inferior vena cava in this cadaveric specimen is flat. Okay. So the clinical significance. Arteries have a lot of smooth muscle, keeps them round. They're having to tolerate the high pressures of the heart. Veins can be flat and they can become compressed. And it's important because if you have a large tumor in your abdomen, like a gravid uterus, and you lie on your back, you can compress the inferior vena cava, reduce blood flow back to the heart, and pass out while you're lying down. And a very large tumor or baby can also compress the aorta, but the vena cava is the one that's most vulnerable. And also when you're looking at a cadaveric specimen, if it's a person that's an older individual when they die, they most likely also have calcium in their aorta, and it becomes solid like a pipe. The aorta does. The problems with the aorta is they're exposed to a lot of high pressures. So they're at risk for these two conditions, the top being the aortic dissection, where a intimal flap, it's called a tear in the intima, breaks through and develops this false lumen between the walls, between these layers of smooth muscle. And then the other is the aneurysm, which are ballooning out. So once that balloon starts, you know how you blow up a balloon and the first part of the balloon is hard to blow up. And then as it gets distended, it gets easier and easier. So about 5 centimeters is when they would do a surgical intervention to prevent this from rupture. This is just an image of what an aortic dissection looks like and creation of a false lumen. And a AAA is called an abdominal aortic aneurysm, when these vessels start to balloon out. Notice how the aorta has some major vessels, celiac vessels here, the renal arteries, supplying blood to the kidneys and also to the major abdominal organs. Treatment, I'm showing you what the newer treatments do, how they're done. Older treatments for aneurysms was a big deal. They had to make an abdominal incision, go in and put grafts around the aorta. Now they can do it percutaneously, meaning you can put in these catheters into the femoral arteries and then put in these stents. And the stents are all just the size of the size of the catheters. And then when they deploy them, then they open up and fill in an area of the iliacs, the artery, the aorta, wherever place that they're needed. And then if they extend, if this area extends further up, like this, they need to put the graft further up and it includes the vessels, they can put little holes in these stents and then put catheters up and extra grafts. And the next picture or video is showing in the operating room with the fluoroscopy machine, looking at placing these stents and threading up grafts to feed in blood supply for the renal. These are the renal arteries, and of course the celiac. Okay, so let's go on to the veins of the lower extremities. Come in 2 flavors: the superficial and the deep. Superficial are these lesser saphenous veins, the greater saphenous veins. These are the ones that are typically taken for cardiac bypass surgery. So if patients have had cardiac bypass surgery and they use them, you'll see the incision come down on the inside of the leg. Surprisingly, that tends to hurt more than the chest incision, than the sternotomy. People complain more about this incision. The deep veins are the ones you don't see: popliteal, femoral, the deep veins. Next question. Your 60-year-old aunt shows you her left leg. Her veins are very large and painful. She's asking you if this is a medical emergency. What are you going to say? Yes or no? The answer is no. Let's go to varicose veins, caused from damage of their valves. Remember, valves, they're one way, and when they become damaged, they can allow blood to flow both directions. And then those vessels distend, they can be clotted, and that causes a lot of pain. They can be treated, they can be stripped. They call vein stripping, to take out these veins, because remember, veins, you have a lot of accessory veins, so you have a lot of ability for blood to get back to the heart from alternate routes. So deep venous thrombosis, on the other hand, is a medical emergency. When you develop deep venous thrombosis, clot can form, pieces of the clot can break off. And if they break off from a deep vein, where would it go? Would it go to the brain, the intestines, the liver, or the lungs? Answer is lung. It would go into the right side of the heart system, go through the right atrium, right ventricle, pulmonary artery, and potentially go off into one or both lungs. So that's what a DVT stands for, deep venous thrombosis. This is a medical emergency. This image is depicting a clot that's formed in the femoral vein and then breaking off and going into the lungs. It can cause lung damage, drop in blood pressure from the release of chemicals that the clots will, with occlusion of vessels in the lungs and death of lung tissue will cause this blood pressure drop. So this is very life-threatening. And also one of the first symptoms you'll see is an altered mental status, where people start getting confused even before they start having respiratory problems. And if the blood clot is very large, it can become a saddle embolus. So instead of getting to the lung tissue itself, it completely occludes the outflow of the pulmonary artery. This is a thrombosed, which means clotted. Thrombosed means a clotted. It's a hemorrhoid. Is this a medical emergency? First, A, no, these are superficial veins, or B, yes, these are deep veins. And the answer is hemorrhoids are superficial veins. If it were mine and they were thrombosed, it would be a medical emergency because it's very painful. But it's only a medical emergency and then it's very painful. So external hemorrhoids or internal hemorrhoids actually can bleed. But bleeding hemorrhoids people can get this confused with potentially bleeding carcinoma. Some of the very most common places for a cancer to form is right there at the rectum. And cancers, if they start to bleed, people will say, "Oh, it must just be a hemorrhoid," and they don't get seen for it. So always with rectal bleeding, check to make sure there's not a rectal cancer. The prevention of deep venous thrombosis is movement. If the patient can't move, if they're not moving, then to use a compression device, which is a pseudo muscles where they're going up and down and keeping that blood moving forward to prevent blood clot formation. So prevention is always better than treatment, but if a large clot forms, then the first treatment is to start the patient on blood thinners to keep the clot from extending, and also maybe dissolving the clot, which is not always so easy. There are some patients that are not candidates for thrombolytic drugs. Say if they've immediately had surgery, you wouldn't want to give them clot dissolvers that would increase the risk of internal bleeding. So they can do this greenfield filter, putting up into the vena cava, opening up the basket, and that catches the blood because the blood is going inferior to superior. And so as this basket opens, the little prongs catch onto the walls of the vena cava and it catches the blood clots. Let's go on to a case presentation. This is a patient that I took care of early in my career. This is only a 36-year-old. She had metastatic breast cancer. She had metastases to her bone, and she had a pathologic hip fracture, which means some of the cancer ate away at the femoral head, and she was having a lot of pain. So she was in the operating room for a hip replacement. So I just want to show you what hip replacement involves. It's a big deal. They have to actually cut away bone. They cut away a piece, they cut away the femoral head. And then to get this artificial hip, there's actually this femoral stem that has to go down into the central part of the femur, the central shaft. So this has to be reamed out, and then to secure that metal in there, they add cement, and then that gets pushed into place. So unfortunately, she went into a massive cardiac arrest as they were tapping in the metal shaft. And it's suspected that she'd had a massive pulmonary embolus. So what type of embolus? Was it a blood clot or fat? And this is showing you the inside of a bone, what the inside of a bone looks like. Notice that it has all these sinusoids. So these open areas where blood and any other foreign material can get directly into the bloodstream. So she had a pulmonary embolus. It was either fat from the bone marrow, or it was actually bone cement that got into her systemic circulation. So this is how you can actually make the diagnosis. On autopsy of lung tissue, you can see these fat globules. You can also see embolus with like a cesarean section. You can see an amniotic fluid embolus that can also cause problems. So a fatty embolus syndrome, you can get the skin rash, coma, organ failure, and death from a fatty embolus. So this is a concern for patients that have long bone fractures. I wanted to show you this image, how as you become an adult, that fat replaces the bone marrow in these shafts of the long bone. So repair of these displaced long bone fractures is particularly important before there's any risk for fatty emboli to occur. All right, last subject, true or false? The heart releases hormones. Now you're going to say true. It's with the hormones are within the atria, and they are stretch receptors. So if you have a lot of extra blood volume, it's detected through the walls of the atria. And the hormone is called atrial natriuretic peptide. And Na is the element sodium. So that's how it got its name, atrial natriuretic peptide. And that tells that hormone goes to the kidneys and tells the kidneys to start dumping sodium. And when sodium gets dumped, water naturally follows. And that's how the blood volume is reduced. So that is why the heart is a secondary endocrine organ. So summary, we went through the major vessels, some case examples, plaque, and also atrial natriuretic peptide as the heart as a secondary endocrine organ. Any questions? Please leave comments. Subscribe to the channel. Thank you.